Great. Yeah, great. Great, yeah. Yeah, no, that's okay. I won't go. Okay. Great. I know how it is.
All right, good morning. Hi, welcome. We're such a small crew this morning here in person, but I know there are a bunch of folks who are joining us virtually this morning. Good morning. My name's Katie Stowers. I am the interim director of the Center for Ethics and a palliative care physician here at OHSU, and I'm so excited to be here with you this morning introducing our speaker, Justin Sanders. Justin, let me pull up my notes here so I get everything right. Justin's an associate professor in the Department of Family Medicine at McGill University in Montreal, Canada. He trained in family medicine and then followed by a palliative care fellowship at Harvard. After completion of his medical training, he did a research fellowship at the Ariadne Lab, where he now serves as the Director of Innovation in the Serious Illness Care Program. His research focuses on understanding and implementing interventions to improve the care and communication equity and relationships between clinicians and people affected with serious illness. We're so excited to invite him here to talk with us today about some of his research. So thank you so much, Justin, for joining us. Terry had asked me to put in a last-minute plug before we get started this morning for the Department of Medicine party that's happening this Thursday at 6 p.m. at the Art Museum in Portland. If you haven't registered, is that okay for me to say? If you haven't registered, please sign up and come join all the fun. So thank you, Justin. So glad to have you joining us here.
Thank you. Is my mic on? Good, okay. So I wonder if I might punish the people who showed up in person this morning and ask you to come down and sit a little bit closer, if that's okay. For those of you online, you're forgiven, and you can stay where you are. So I'm really grateful for the opportunity to be here today with you. I appreciate the French sweater because now I live in a place where people speak French. But I'm really grateful to be here today to share with you some of what I've learned over the years and hope that it's relevant to some of what's happening here at OHSU. I've never actually been to OHSU before, although I've had many friends here, and it's a beautiful place to be up on the hill. And I'm looking forward, I think I get a chance to take the tram later, so I'm really looking forward to that. I will say that I don't have any financial disclosures or conflicts of interest. I will also say, however, that I'm a white, cisgendered, able-bodied, and heterosexual, middle-class, married male palliative care physician and researcher, and a father of two. And I also live in Canada now. So I think it's important to mention these not out of atonement, but because these are the lenses through which I see the world. And the lenses that I try to look around in doing my administrative, clinical, and research work. I have some objectives, some of which have been posted before I got here, that at the end of this session, you'll be able to reflect on the role of communication in the experience of people with serious illness. That you'll be able to describe a body of research that supports the notion that communication is critical to advancing healthcare equity, and that you'll be able to integrate serious illness communication principles and tools to improve the quality of relationships with patients and their caregivers. So I was thinking about this somewhat cumbersome title for this talk, and when you're invited to give a talk, people say, can you give us a title and some objectives? And it's like months in advance, and you think, okay, what am I going to talk about? And so, so I came up with that somewhat cumbersome title, which you saw at the beginning here. And then as I was putting this talk together, I was thinking, what do I really want to talk about that meets these objectives? And how I would reframe this now is what we can learn from palliative care principles, evidence, and tools to advance healthcare equity. And because grand rounds can be very formulaic, I thought I would try something different. So this is a grand round in 3 acts. Act 1 is the education of a palliative care physician. So I might have to look around me to see where I am. But this is a picture of me, actually, lying on a couch asleep. It's about 8 o'clock in the morning, I think. And this was the morning that my best friend, Melissa, died. This is Melissa and I, about the age of 5, aptly dressed. And this is Melissa and I somewhat later, probably, well, certainly after the time that she was diagnosed with cancer. She was diagnosed with ovarian cancer at the age of 18. And Melissa was my oldest friend. I knew her from before I was born, if you could say, because our parents were really close friends. And what transpired is she developed cancer while she was at school at a university in Ohio. And over the next 3 years, she was treated for her cancer. She went through periods of remission, as people do. And it was in late October of my junior year of college, we were 21, that I got a call from my mom, who was in Los Angeles, which was where Melissa lived. And I was in Philadelphia, where I was going to school. And my mom said, you know, the doctors don't think that Melissa's going to live through the night. She was at home, fortunately, with a team of nurses that was helping to care for her. Well, and I didn't know what to do. I had my finals, or my midterms, I guess, in the days to come. And I was pretty devastated in some ways. We'd been close our whole lives, but hadn't necessarily been always in touch through the course of her cancer treatment. And I was a little bit surprised that it had come to this. I didn't really know. And so I wrote her a letter, something to the effect of, you know, this has been a really hard journey, and you know, you can let go. And I bought a plane ticket for Friday because I knew I had to get through my midterms, and I knew I wasn't gonna, if she was gonna die in the night, I knew I wasn't gonna make it there. So I got on a plane on Friday, and she was still alive, actually. And I had this feeling in some way that she was maybe waiting for me, which for those of us who do this work, sometimes, you know, you feel that that's what happens. So I got to Los Angeles. It was a beautiful, sunny autumn afternoon. And I remember sitting in the car of my friend who had picked me up, who was also Melissa's close friend, and just thinking, please don't die on the way while I'm on my way from the airport. That would be unfortunate. But I got to her house, and Melissa was lying in her bed, somewhat pregnant with tumor. I mean, she was really, it was a remarkable image. I mean, she had these sort of heavy drapes in the room, and there was music playing and candles lit, and she was sort of lying in bed, you know, pregnant with tumor, in and out of consciousness. And for the next probably 12 hours, she and me and two of her other closest friends sat with her and told stories and jokes and laughed and remembered her, and it was a gift. It was a profoundly special time. And she was, as I said, in and out of consciousness, and but we made meaning of this experience together. Now, I stayed up through the night. I knew I wanted to be a doctor at this point. I think I'd always wanted to be a doctor. And I was curious about what was happening. The nurse was drawing up syringes of fentanyl and giving them to Melissa because she was in a lot of pain. And so I stayed up with the nurse through much of the night doing the same, like kind of learning what she was doing, drawing up syringes of fentanyl, passing them to the nurse, which she would give to Melissa. And then I went to sleep at some point, and that was me on the couch, as you saw. And someone woke me up at some point, and they said, can you come help us? We want to get Melissa from a chair where she'd been sitting back into her bed. And so I went into the room, and I helped get Melissa back into the bed, but something felt different in the air. Something was happening, I knew. And the head nurse, who I'd come to know through the hours of being with her through the night, had asked everybody to leave the room. And I said, I'd really like to stay. And her grandmother, Grandma Jane, said, I would like to stay too. And so Lisa, the nurse, myself, Grandma Jane, and Melissa were in the room together. And Melissa was in her bed, and Grandma Jane had her right hand, and I had her left hand, if I can recall. And we spoke to her while the nurse, while Melissa was really in obvious pain, and while the nurse drew up more syringes of fentanyl and gave her kind of what felt like dose after dose of medication. What I later learned is that the nurse herself had promised Melissa that she would never let her be in pain. And Melissa had a lot of pain. Now, you might ask, like, where were Melissa's parents in all of this? Well, they were upstairs, actually, in the same house, really unable to face what was happening at all. You know, it's, as a father, it's hard to imagine what it's like to lose a child. It's against the natural order of things as we construct it. And they couldn't face it. And I think that through her dying breaths, they were in their room hoping that she could get better in some way. So Grandma Jane and I held Melissa's hand and we talked to her. And I had no idea what to say. But I said things that I thought would be comforting, things about maybe butterflies carrying her off into the wind or something like that. And then she took her last breath. And what I recall was this, as I left the room, was this feeling of kind of uncomfortable elation. There's no other word I can, you know, I've tried to find other words to describe what was happening, but I felt this like sense of elation. And over time, I think I felt like, I realized that what I felt like was that something healing had occurred. In dying, this person, my friend, Melissa, had been healed in some way of something, of her cancer, of the burden that she was carrying throughout. And so, you know, I think about this story a lot, in fact, probably every day. And I think about how, you know, I kind of learned about the need for palliative care before I even knew what palliative care was. Because I didn't know what palliative care was. So, a few years later, I landed in this place. This is the Bronx. This is East 193rd Street in the Bronx. This was the Family Health Center at Montefiore Medical Center where I trained. It was a very special place, sort of infused and steeped in principles of social medicine and liberation theology and their activism. It was a really special place to train. It was in the poorest congressional district in the country, far from the place where I grew up. And one of the patients I took care of there over the years was this woman. This is actually a composite image that I made using Midjourney, which is something you can do now. You don't have to actually look for free images anymore. You just make them. But I put in the characteristics of this patient that I took care of over the years, and this is what popped out, and it reminded me about this woman, Mrs. Santos, who was this Puerto Rican woman in her mid-60s who had, you know, every conceivable medical problem. She had diabetes and hypertension and dyslipidemia and atrial fibrillation, which landed her in the hospital seemingly every few months. And as an intern, when I met this woman, I was so overwhelmed by the immensity and of her medical problems and how intractable they seemed. And at the same time, this woman, we loved each other. I mean, at first I didn't know what to do, but she was this incredibly gregarious woman who would come into my clinic, and I would almost invariably only ever see her after she'd been to the hospital, because it happened frequently enough that every visit that would have been like a typical Q3 month primary care visit for this woman, it was a post-hospital visit because she'd always end up in the hospital. And she hated the hospital. And I think I even met her in the hospital, in fact, and that's how she came to be my patient. I knew she hated the hospital, and I would go see her in the hospital, and she would complain and say she wanted to get out of the hospital, and she'd go home. I got to see her in her home once, which was, you know, for people who've done home visits, is a really special way to get to know somebody. I knew about her family. One day when I came to the clinic, I walked out of my room from seeing someone, and the cardiologist who was embedded in our clinic said to me, you know, I just saw Ms. Santos, and she probably doesn't have that much longer to live. You know, I would expect she might die within the next year. You should really talk to her about that. And I think I probably tried to look cool and said, okay, yeah, I probably should. I had no idea what to say. I didn't know what to do. I mean, this was a woman who had, you know, she had a bunch of medical problems, but she kept going into the hospital. She kept coming out. She would really return to mostly her baseline function. And And it was some matter of months later, having seen her in the hospital and out of the hospital probably another couple times, that I went on vacation. And I came back from vacation to an email in my inbox saying that she'd been admitted to the hospital and she had died. So I sat in front of my computer and I thought, oh, you know, it was sad. I'd lost this person that I cared for as a patient, as a person. And I felt like I'd missed an opportunity for something. I'd been given this opportunity by this cardiologist. One could ask why the cardiologist didn't take the opportunity himself, but I think he knew that I was an important position in this person's life, and so he asked me to talk with her about it, and I didn't know what to say. Then I became a palliative care doctor, and I learned about this person. So this is a person named Cicely Saunders, Dame Cicely Saunders. And she is one of the sort of people, well, she's the kind of the godmother or grandmother who started our field in some ways. She was a remarkable person because she started off her career as a nurse. This is in the United Kingdom. She joined the Nightingale nurses as part of a patriotic response to World War II. But she had somewhat crippling back pain, and so she stopped nursing and she became an alder woman, which is basically like a clinical social worker. It's what we think of now as a clinical social worker. She was struck in her work as a nurse and as a social worker by how poorly we took care of people who were at the end of life, particularly people with cancer who tended to die in agonizing pain, as she found it, and she was really troubled by this. And she wanted to do something about it. As is true in some places still, social workers were somewhat farther down the hierarchy than physicians, and she was encouraged by a physician mentor to actually go to medical school, which was uncommon at the time. This was in the early 1960s, I believe. And she became a physician. And then she started to learn about what it was like to take care of people who were dying. She worked at a place called St. Joseph's Hospice in Hackney. And it was there that she sort of started to formulate some of her ideas about taking care of people at the end of life, people with serious illness, people who we now think of as people with serious illness, but really people at the end of life. And she developed what I think is like the first of two radical ideas at the core of palliative care. By the way, this is not a talk about palliative care. Just so in case people are curious, in case people online are curious, this is not a talk about palliative care, but it's a talk about how I became, it's a little bit about palliative care. But it's not wholly about palliative care. So she articulated what is really the first of two really radical ideas that inform palliative care practice and philosophy in my mind. The first of which is total pain. Okay, so this is a graphic that represents this idea that there are multiple forms of suffering in the course of serious illness and at the end of life that intersect with each other: social, existential, spiritual, physical, and that our assessment of these is incomplete in some ways without assessment of the others because of the way these forms of suffering intersect with each other, interact in some ways. This is a really radical idea. I mean, it feels like, people talk about total pain, but I don't think people talk about how radical an idea this was. I mean, it's radical for one significant reason, which is that it disrupts this sort of Cartesian duality that is at the core of medical practice and training, even today. That is the idea that there's the mind and there's the body. And we see this. If it's not of the body, then it's of the mind. If we can't figure it out, then you're crazy. And that really is still something that we contend with in our medical practice and that patients struggle with, because nobody likes to be told that something's in their head, and yet sometimes that's the feeling they get when we can't figure out what's wrong with them. Now, this idea says, actually, there is no mind and body. These things intersect in ways that are really important. It disrupts this Cartesian duality in a way that's really radical. It's still radical today. It's hard to teach people this. I have palliative care colleagues who say, well, it's not pain, it's total pain, which is essentially saying it's not of the body, it's of the mind. So even now, I think that this is something that we can struggle with, is what is total pain? Is it a clinical construct? Is it even useful as a clinical construct? Kind of. That's the first radical idea. The second radical idea was articulated by this gentleman. This is actually my predecessor in some ways. He was the first person to hold the chair that I hold at McGill, and he was the first person to coin the term, he coined the term palliative care. He was a urologic surgeon at McGill, and he didn't really, I didn't think much about people caring for people who were dying, but he went to see a lecture by this woman. This is Elizabeth Kubler-Ross, who is the Swiss-American psychiatrist. Many of you have probably read some of her books. And in 1971, she came to McGill to give a lecture. Is that too loud? I'm going to go down a little bit. To give a lecture about her work, and it was packed. And Balfour Mount writes about this in his memoir. And he went to see, and he was like, whoa, what is this lady talking about? I mean, she was doing something radical too, which is that in hospitals, she was trying to figure out the experience of people who were dying. She was asking them, talking to them, as if they were people about their experience of dying, which was radical in the 1960s. And so she came to give a talk about her work, and he was really intrigued by what she was talking about. So he went and picked up her book, and he noticed that in the references of her book, there was this references to this woman called Cicely Saunders. And so he's like, what's this woman doing? And so he called her up, as you used to do. He picked up the phone in the hospital in Montreal, and he called St. Christopher's Hospice, which was the hospice, the first modern hospice, we say, in Sydenham in southeast London. And he called her and he said, I'd like to come spend some time with you. And she basically said, well, you better prepare to get your hands dirty. This isn't going to be a vacation for you. And so Balfour Mount got on a plane and he went to England and he spent 3 weeks, and this remarkable friendship grew out of this time. And so he came back home to Montreal and he said, I really want to do something with this. I want to start a hospice in a hospital. It would be the first of its kind. Have a hospice in an academic tertiary care hospital with a palliative care consult service, like the whole thing. It wasn't called palliative care though, because he wanted to create a hospice. That wasn't going to be possible in Quebec because there was the worry was that there was this strong association between the word hospice and almshouses for the poor in France. And so he said, I think he came up with it in the shower, that he was going to call it palliative care because of its connotation of supporting and cloaking from the Latin. So he called it palliative care, and in 1973 they started seeing consultations and palliative care consultations in the Royal Victoria Hospital in Montreal. And in January 1975 they opened the first hospital-based palliative care unit, as such named. Now, that's a little bit of history. What I think is more important is this second radical idea that was articulated by Balfour Mount and other colleagues, among them Michael Kearney, which is the idea that healing is possible through the course of serious illness. Now, we all work in healthcare, and I think we know that for most people, and clinicians in particular, dying is just a series of failures. You know, your pancreas fails, your lungs fail, your liver fails, eventually your heart fails, or your brain fails first, and then the rest of it fails. But it's a series of failures. It's built into how we talk about it. Even when we talk about cancer treatment, we've all heard physicians say things like, well, the patient failed the treatment, which I hope none of us will ever say. The treatments failed the patient. But failure is built into dying in some ways in how we think about it. And Dr. Mount and his colleagues were saying, actually, there's something important that can take place here. And he conceptualized healing as an experience as a relational process involving movement towards an experience of integrity and wholeness. This is also radical, this idea that people can somehow experience a sense of being more of themselves or of growth even through the course of serious illness. And yet, in some ways, it's like highly intuitive. I mean, I guess for those of us who have cared for people, we know that this is possible. And in some ways, this was, I think, a little bit about what I had experienced in taking care of my friend, Melissa. Balfour Mount said something else that I think is really important. And I'm not at my podium, so I'm going to not try to read it backwards through the glass. But what we're trying to do in palliative care and all medical care is establish healing connections to be experienced by those who are ill or dying and their families. I think this is so beautifully said. So in some ways, as we move through the rest of this talk, I think we're going to talk about how we build these connections, because, you know, in my education as a palliative care physician, I think I've come to the place of understanding that this is the most important thing that we do. And in fact, the most important thing that we do in all of healthcare. I'm going to tell one more story, because this is I think my education as a palliative care physician is ongoing. I moved to Canada from Boston a couple of years ago, and Canada has medical aid and dying laws. They're different in their implementation than they are here in Oregon, but where people mostly self-administer or entirely self-administer medications. In Canada, that happens very rarely. It's allowed, but it happens very rarely. In fact, most cases are what we think of as euthanasia, where a physician administers a lethal dose of medicine. This is a woman named Janie Boulanger, and she gave me permission to talk about her. I took care of her in the fall of 2022, and she was a person who presented to our clinic in just the most agonizing pain. I think she hadn't had a bowel movement in like 2 weeks, and she was curled up on the bed asking to die. Just help me die now. And I was with a medical student, and I was like, okay, let's see what we can do here. I think we can probably, my hope is that we can get out of this situation, and she won't want to die, at least right now, because requests for dying made under duress are like never a good situation. So we in fact admitted her to our palliative care unit, got her cleansed, got her pain under better control. And at the end of that, she said, you know, I still want mate, how people say it. And I was a little perplexed, honestly, because she was comfortable in some ways. She was a teacher. She taught kind of like community college here. It's called CEGEP in Montreal. And she taught literature. And as I sat down with her, we talked about her fears about dying. I was, you know, in some ways it feels like in Quebec everybody's read The Death of Ivan Ilyich, like everybody's terrified about what it's going to look like to die. But we talked about literature, and she loved American crime fiction, and which I'm not a big fan of, I'm not well read in. But we had a lot to talk about in terms of what she did as a teacher and her writing and her reading, and she loved films. And I said to her, you know, tell me more about, you know, you can do these things now, and tell me more about how you're thinking about this. And she said, well, I've lost these things once, and it was awful, and I can't imagine losing them again. And for this reason, I would prefer to die. And I thought, I have nothing to say to that. On the morning that she died, I went into her hospital room, and I said goodbye to her. This is a woman I think I'd met 3 times. But I asked her if I could tell her story, because it felt very resonant to me about some of the complexity of medical aid and dying and of life in general. And she said I could. And we shared our gratitude for having the chance to have met each other. And then as I was leaving, I said something really awkward because I didn't know what to say. I said, see you later. Which just goes to show you can teach communication for years and still not know what to say sometimes. And then she died. Now, you might say, well, that was a failure of an intervention of a palliative care clinician in some way. And I don't think it was. I think we had something in the 3 times that we met each other. We built something in the 3 times that we met each other that felt important to her and to me, and to her partner. And that was a relationship. And so, again, the question I have now is how do we give everybody the opportunity to benefit from these relationships? Okay. Act 2. This is some science of serious illness care. So I want to give you some of what you were expecting today. I think it's important that we ground ourselves in a definition of what serious illness is. So serious illness is a health condition that carries a high risk of mortality and either negatively impacts a person's daily functioning or quality of life or excessively strains his or her or their caregivers. This is work that Amy Kelly did to help kind of define what a serious illness was based on some really rigorous research looking at the NHATS data and Medicare data to try to understand what it was, who were the people that were at highest risk of dying. And it was those people who had medical conditions and also a significant loss of function. So this is kind of a helpful place to ground ourselves in. I'm going to ask a series of questions and then try to answer them a little bit as a way of building towards what is the third act of this talk, which is how we make this better. How do we improve equity in healthcare through communication? So first of all, like, what are the inequities? Well, I think this graph shows, this is from the Unequal Treatment Revisited report from the National Academies of Medicine 2024, and it shows that there continue to be significant gaps in life expectancy between white people and other people of color. And you know, it's improved a little bit over the last 20 years for Black people, but the gaps haven't really improved or closed much. And there's some dismal statistics on American Indian or Alaska Native individuals. So this is a problem. And to what can we attribute these differences in life expectancy? Well, I think it's important to say that these disparities start from before people are born and continue through the end of their life, all along the way. But there are huge differences in the incidence, the risk factors, the incidence, the treatment, and the outcomes related to various serious illnesses. So various serious illnesses, excuse me. So this is, for example, I'm not going to get into the data here, but I'm just going to show you that in virtually every serious illness, there's evidence to suggest that there's significant disparities in how we prevent, diagnose, and treat these illnesses. So this is cancer, this is end-stage renal disease, this is liver disease, this is COPD and asthma, this is heart failure. There's plenty of evidence to suggest that we don't do as well for people from marginalized communities, including, of course, those characterized by racial minority groups. So what do we know about the differences in patient experience? So it's one thing to say, okay, like we're not doing as well. What does that due to? But you know, how are people feeling in our healthcare system? This is from research that I was part of, and which we asked people about their experiences of racism in healthcare. And this is just some snippets of this, but I'll just share with you how, you know, a little bit about what it's like for people. So this person said, I don't know if it was just horrible care at this particular hospital. It wasn't even just one person. It was a lot of people that I had encountered over those 3 days. I don't know if it was just you all kind of suck. A lot of us try not to overreact, and we don't always want to go to what other people call the race card. Then again, since it's not explicit most of the time, you kind of don't go there, and you feel like, I'm just not getting good care. In the back of my mind, though, I'm saying I'm not getting good care because either they think I'm poor or uneducated, or because I'm Black, or because I'm a woman. And so that's why I didn't speak up. This was a question to one of 5 focus groups of people who identified as Black or African American about their experiences in healthcare. Another person said, most of these experiences are insidious. No one's telling me to my face, I'm treating you differently because you're Black. Well, you must have lots of kids, or those types of statements or questions, or the whole thing about high blood pressure. Well, you're obese, of course you have high blood pressure. It's like, assume that, well, you're Black and you're obese, doesn't matter how much obese or not. Sometimes you don't look it, but you still are, or sometimes it's just a little bit over the obese line, but they don't care. It's kind of like, oh yeah, you're Black, so yeah, you're gonna have high blood pressure because technically you're obese. So it's things like that. You know, these are just 2 snippets of like a veritable horror show of experiences that we heard about in asking people about their experiences of racism. Just people who identify as Black or African American. And really, they just want to be treated as human, and it's a bar that is so low that it's shocking that we fail to get over it so frequently. How do we explain these disparities? Well, you know, I think this was from a paper about inequities in heart failure care and outcomes. I actually this is a pretty robust conceptual model in my mind. Talks about engagement, structural, so individual issues, structural issues, interpersonal issues, community issues, health system issues, including clinician bias, which we heard a little bit about, I think, in those quotes. Interpersonal issues, trust and patient-clinician relationships. You know, I think it's important, like, we can't fix all this stuff as clinicians. So I think it's really important to pay attention to the things that we can, where we can intervene, okay? And so I think it's important that we look at models like this and say, what can we do? I can't necessarily fix someone's food access and security, but what I can maybe do is help them feel that I care for them as a doctor. What's the effect of palliative care? So it's changing directions a little bit. We've talked a little bit about inequities. I think it's important that we ground ourselves in some evidence about what palliative care can do. This was a landmark study. Many people will be familiar with this study. This was Jennifer Temmel and her group at Massachusetts General Hospital describing a randomized controlled trial of people with advanced lung cancer who were either randomized to early palliative care, which was conceptualized as within 8 weeks of diagnosis of their metastatic condition, or usual care. This was just a table because it's important to put tables in slides. But I do want to show you that this was a group that had relatively high rates of anxiety and depression because it's anxiety provoking, certainly at a baseline to have a serious illness. And a lot of people experience depression. What this shows is that people in the early palliative care group had lower rates of depression and anxiety at the end of this intervention. This is really important. There aren't a lot of pills that will do this, and I'll show you another study in which we see similar or perhaps even greater effect. This was the finding that blew everybody away, which is like, how do people on average live longer? This is like, I think this surprised everybody. I think it's important not to show this, I think it's important not to say that palliative care helps people live longer, but rather like it doesn't kill people, it doesn't shorten their life. And that's what I think this was important about this. But like, what happened here? Everybody was like, what did you guys do to help people live longer and feel better? How did you do that? Well, so this is an analysis of the initial consultations that they had in this study. This was done by Juliet Jacobson and others from that trial. And they looked at like the total time and how much time was spent, talking about different things. And you can see that illness understanding and coping were a significant part of that total time, as was symptom management, of course. And the others, I don't know, decision-making, planning, and referrals, I think those of us who do palliative care are familiar that stuff can come a bit later. But it's really important to understand how people are coping. This was another analysis by some people from that research team to understand what mechanisms might explain a survival benefit in palliative care. And you can see that like a big part of this is in the middle. I don't have a laser pointer on this thing. Oh yeah, I do. Illness knowledge and understanding and coping behaviors. Quality of life, all these, they thought that the team, the practices and processes of palliative care and what they did led to different health behaviors, including in some cases maybe not taking anti-cancer therapies, and that somehow impacted survival. Okay, I'm gonna move quickly through this. So great, this is awesome. Like palliative care is, we know, I think there's people in this room, we know palliative care is great. But the question is the supply and pipeline of palliative care clinicians big enough to meet a growing need? Well, this is a study by Arif Kamal and others, and this is not the only study of this kind that looks at, they did some modeling of palliative care. They asked a bunch of thousands of palliative care clinicians, like, what are your plans in the next 10 years, next 5-10 years? What do you expect to happen? They looked at the number of physicians, specialist trained physicians in particular in the pipeline, and they looked at the number of people who were anticipated to be seriously ill, and you saw this growing gap. Uh-oh. So the question is, how can we deliver palliative care if we don't have enough specialists? Well, so this was a study from our research group in Boston where we looked at an intervention that was focused on communication. It was a quality improvement intervention focused on communication, where we trained clinicians to use a serious illness conversation guide, some of which many of you will be familiar with this because of work that's happened here, and then we measured outcomes for patients to see what happened. And what happened? Like, well, if you look at this, there was no differences in therapeutic alliance. These were oncologists, not palliative care clinicians. But if you look, there were reductions by half, sustained reductions by half or nearly half in moderate to severe, in the prevalence of moderate to severe anxiety in these, in the patients who had a conversation. There's no pill that does this. And yet, this is remarkable. Why isn't everybody doing this? That's what we got to figure out. How do we get everybody to do this? Because these weren't palliative care clinicians. They were just doing something that palliative care clinicians had learned to do. Okay, so that's not bad, right? But like, so what else? So these patients describe better illness understanding. When I talk to my family, I tell them what the doctor said. It's not a death sentence, but the doctor has to tell us. Now we're treasuring every day we have together. They described improved relationships with clinicians. I felt more valued as a patient, like we get a little bit closer. Increased focus on practical planning. We talked about their bucket lists, making them, completing them. And this wasn't bad for clinicians either. Like, how did it affect them? Well, they felt like the Serious Illness Conversation Guide was effective and efficient and increased their satisfaction in their role. It reduced their anxiety in having serious illness conversations and improved their patient-centered communication skills, at least as far as they rated them themselves. And one clinician in another study said, I feel more comfortable and empowered to have these conversations with my patients. Now I think back to my patient in New York, who I took care of and had no idea what to say. And I think about how this might have helped me do something that could have had a significant impact on her life. What does this have to do with equity? We asked patients in South Carolina, Black patients in South Carolina, what they thought about this guide, because this was developed in Boston with a lot of white, educated, middle-class people. And so we took this guide on the road and we took it to rural communities in South Carolina. And we modeled this conversation for them. We showed them what we thought it might look like, and we gave them the guide. And we said, what do you think about this? And patients said things like, the doctor talked like he's a human being and he acts concerned, you know. It says patient because we did this with both patient groups, people with serious illness and community members. One of the community members said, I think the conversation guide will be good because some doctors don't know how to really talk to us. But if we, seriously ill or not, if we consider these questions, we'll have something on our side besides having nothing. I believe what the conversation is trying to do is to help the patient have more control over his or her situation. The question gives the patient control. And another one said, you can't make an informed decision if you haven't been informed. Which feels obvious. So, Act 3, an act of love. We don't talk about love a lot in medicine, but it's interesting to me because one person did. So people are familiar with Avidus Donabedian, Donabedian's Malady of Quality Improvement. This is one of my favorite quotes. He said, ultimately, the secret of quality is love. If you have love, you can then work backward to monitor and improve the system. Blows me away every time I read that. So what do most people think of when they think of Donabedian? They think about this model of quality improvement that has structures, processes, and outcomes. That is, the structures are the physical and organizational characteristics where healthcare occurs. The processes are how we actually deliver the care. What do the services look like? And then, of course, there are the outcomes, which are the effect on the status of patients and populations. Now, this talk is framed around equity, right? So certainly what we're trying to improve, at least in part through improving quality, is equity. So what is equity? Let's just review very quickly. Equity, sometimes you see a model of 3 children of different sizes trying to look over the fence, and the littlest child gets the biggest boxes, and that's what makes equity, right? But the truth is that people are the same, right? And they're not having the same access. They're not of different heights. They're not children of different statures. And what we're trying to do is give people a view over the fence in some ways. This is an adaptation of that model. But what if the view over the fence looks like this? A barren desert of inhumanity. You know, a lot of the focus on equity in healthcare is about how we give people equal access to care. But I think for some people, even when they get access to care, it doesn't look very good, right? It's characterized by really poor experiences of communication. So when I think about how we improve equity in healthcare, I think we need to change the view a little bit, right? And we have some of the tools that we need to change the view. Now, I think we should remind ourselves, like, what is the experience of people with serious illness? Well, like, what are we trying to we're trying to do here. This is what it means to have a serious illness. Physical discomforts due to disease or treatment, complex decision-making, treatment decisions involving risk of hastened mortality, heightened anxiety for patients and families, and finally, personal or community histories of healthcare trauma. So how do we address that? I think this is how we're situating ourselves for how to address this issue. People will be familiar with the Serious Illness Conversation Guide. I'm not actually going to go through the history. We can talk about this some other time, but it started a conversation between Atul Gawande and Susan Block and was developed at Ariadne Labs. I guess I am going through it. The idea is that it's part of a systems level of approach, and I will say it's in use in health systems around the world, including this one. And I think the question is, how do we make sure that this is something that everybody receives? So I'm not going to go through this because people will be familiar with this, but this is patient-tested language. It's been through many, 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 many iterations. This is a new version of the guide that came out in early 2023 with a little bit of different language. That's one tool. I'm going to show you another tool, though, because I want to show you something new. This is something that we've been working on also at Ariadne Labs, which is a tool about explicitly addressing racism. This is called the TRACE tool, and which stands for Talking About Racism to Advance Care Equity. And so this is just another tool that we're trying to understand the effects of in clinical practice. I'm going to show you a little video.
Hi, I'm Justin Sanders, a family doctor and palliative care specialist. I'm here to introduce you to a tool to support meaningful conversations about an important issue in clinical practice, racism. As healthcare professionals, we understand that racism is a societal issue with significant public health consequences. People of color and others from marginalized communities are likely to have had negative and even traumatic experiences in healthcare due to systemic factors, real or perceived bias, or discrimination. We believe that talking about racism can advance care equity. Tracing these experiences can be therapeutic, build trust, promote compassion, and help address barriers to decision-making related to important medical issues. The TRACE tool provides a patient-tested structure and language to support these conversations. Consider the story of Dr. Mann and his patient, Mr. Smith, a 70-year-old Black man who recently broke his hip. Dr. Mann knows that a hip fracture can be a pivotal moment in someone's health and wants to engage Mr. Smith in advanced care planning, but he worries that Mr. Smith might perceive this as an effort to limit care. Dr. Mann remembers the TRACE tool, which helps clinicians support conversations about difficult experiences within the health system. Dr. Mann reflects on how racism could have affected Mr. Smith and thinks about how he might show Mr. Smith that he cares for his well-being. When Mr. Smith arrives for his visit, Dr. Mann greets him warmly and checks in about Mr. Smith's goals for the visit. He uses the language on the tool to engage Mr. Smith in a discussion. Some of my patients have had difficult experiences in healthcare that may be due to racism, and that make it hard to trust that they will get the best care. Some patients have found it helpful to have these experiences acknowledged. I have also found it helpful so I can better understand people's experiences. He asks, "Would it be okay if I ask you about whether you have had experiences like this?" Mr. Smith, a little surprised and a little unsure, agrees. Dr. Mann asks him, "What experiences of racism in healthcare, for yourself or others, might help me to know you and care for you as a person?" Mr. Smith takes a deep breath and describes a few incidents, including some in Dr. Mann's clinic, that made him worry that he and his family were being treated a certain way because of their race. Dr. Mann listens deeply and compassionately. When Mr. Smith finishes, Dr. Mann responds with gratitude. "Thank you for sharing this with me. I'm sorry this happened to you. It's not the medical care that you deserve. If it ever feels helpful to share difficult experiences with me, I'm here to listen." Mr. Smith nods. He seems more relaxed. Dr. Mann says, "It's important to me that you get the best care and feel well cared for." Then Dr. Mann asks if they might talk about the experience of his hip fracture and his hopes and worries for the future. After the visit, Mr. Smith feels that Dr. Mann may understand him better and really cares for him. Dr. Mann understands more about the experiences that Mr. Smith has had and commits to addressing the experience of patients of color in his own clinic that he'd not been aware of. These conversations have the potential to foster meaningful relationships that benefit patients and clinicians alike, and that contribute to a healthcare environment where all patients feel respected and valued. We encourage you to try the TRACE tool.
So this is just another example of a tool that enshrines some of the skills, there we go, some of the skills that we have learned over the years in palliative care. And really just good medical care. And I think it's important to say that these tools are not enough, and nor is the communication skills training that goes along with them. It requires more than teams, more than palliative care teams, more than communication tools. It really requires a system. And you know, this is one example. This is an early iteration of what we developed at Ariadne Lab to sort of support the idea that these conversations happen within a frame in some ways that we create, that it involves understanding who the right patients are, preparing those patients to have these conversations, reminding clinicians to have them, training clinicians to have them, and helping them document them in ways that are useful across the health system so that they can be actionable. And this is really the hard work. I mean, this is the work that we have to figure out together over time. But it's not, I think the thing that I want to come back to is, what is all this in service of? What are we shooting for? How are we going to fix the inequities in healthcare if we can't fix all the structural things? I want to come back to this idea of Dr. Mountain, what he said about what we're trying to do in palliative care, which is to, and all medical care, is to establish healing connections to be experienced by those who are ill or dying in their families. What do those connections feel like? What should we be helping clinicians understand as an outcome of these conversations that we teach them to have? How can we use that information to motivate people to want to change the culture in which we provide healthcare, recognizing that this is what we're trying to do? Anthony Suchman and colleagues wrote a lot about relationship-centered care in the late 90s and early 2000s. And one of the things they said that I love that helps us understand that connections and relationships are an outcome is that connection is often marked by a physiologic reaction, such as goose flesh or a chill, by an immediacy of awareness of the patient's situation, as if experiencing it from inside the patient's world, by a sense of being part of a larger whole, and by a lingering feeling of joy, peacefulness, or awe. When I read this, I recognize the sensation that I had walking out of Melissa's room after she died. And I recognize the feelings that I have with patients all the time that I'm kind of taught to ignore in some way as a physician. I think when we want to motivate people to change the culture in which we provide healthcare, we have to really show them what we're looking for, which is good for, not just good for our patients, but good for us. And I think this is what we're shooting for in some way. So thank you again for the opportunity to be here and to share and to learn. And we don't have a lot of time, but I'd be happy to entertain any questions now or after. So thank you very much, and thanks for the people who are online. Who of the thousands amongst you would like to ask a question? Yes. Yeah. 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 There's two things about time. One is that we don't have a lot of it because we live in a very busy world, but it's a world that we construct ourselves in some ways. The other is that time, the appearance of time and our worries about it are driven in part by our own anxiety about having these conversations. One thing that my experience as a primary care doctor was such that I had 15-minute visits to see people but you could be sure that there was at least one visit a day that was going to take an hour. And I was not going to have any control over what that was. That hour was going to be completely out of my hands, and it was going to completely ruin the rest of my day. And I think that's true for a lot of us. There's a lot of ways in which what we encounter in terms of time pressures is unexpected. And I think the question is how do we as a system create construct time in ways that is more expected, right? So when we recognize that someone needs to have these kinds of conversations, rather than being surprised by the conversation taking an hour because we don't understand, because a family is feeling like their world is falling apart and they need somehow for us to help make sense of it for them. How do we take a less reactive approach and a more proactive approach? In some ways, that's one of the things that I find important about this work in trying to improve communication. It's one element of trying to be more proactive in meeting the needs of patients with serious illness. Because it's amazing to me, people with serious illness have relatively predictable needs within a relatively predictable time frame, and yet we are constantly, as health systems, on our back feet, trying to, reacting to what happens. And so the question is, I don't know the answer in every system, context is the soul of implementation. But I think that if we all recognize that these kinds of conversations are important and that they don't have to happen for every patient every day, then we can start to say within our teams, like, how do we create time to meet the needs of this person who, in the ICU, you have family meetings in the ICU, right? I have a friend, one of my closest friends is a nephrologist at Mass General, and I gave him the first iteration of the conversation guide in 2012. This guy has the reputation of being the wizard of family meetings, and all he ever does is use the conversation guide. The people in the ICU, when he comes in, they're like, and all he ever does is use the conversation guide. And these conversations take 10, 15 minutes for him, but it makes a profound difference in the care of the patients. And I think that what I find frustrating is when I get asked to see a patient as a palliative care physician on the 100th or 300th day of admission to the ICU, and I sit down with those patients and I just ask them these really simple questions. And sometimes they didn't even know what was happening. They couldn't contextualize all the things that was happening. And I think the question is, so how do we create the time that, I may spend, 45 minutes with them, and I may have the luxury of doing that. But it seems to me that someone along the way could have spent the 15 minutes to have a conversation like this if we had just sort of planned and been aware of the need for this in a proactive way. So that's how I think about it. Also, you should always sit down, because that's, when you sit down, people perceive you spend more time with them, and when they perceive that you spend more time with them, they think you care more, which is good. Oh, I don't know. Maybe our tech person can see it. I don't know if there are any questions on chat.
There is one from Katie Lossie. In creating the trace model, what were the principles that you felt were most important to include that guided the phrases chosen? Oh,
that's such a good question. So we had this, I'm really lucky to be able to do this work. I'm like a white kid who grew up in Utah, which is like one of the 2 whitest states in the US. And I have had the amazing privilege of working with people from very diverse backgrounds to do this. We recruited an advisory board. We used an experience-based co-design process where we recruited an advisory board, and we did qualitative interviews with clinicians and with patients to try to understand their experiences, their worries, and their perspectives on what these conversations might hold for them. And then we put language out there, building on our experience, and we workshopped it and tested it over time. We put it in front of patients, and there's actually, I should say, this is still early work with this tool. I'm excited about it, which is why I wanted to share it. But we worked with the Patient Advocacy Foundation, which is a national group of patient advocates, to try to understand the perspectives of people with serious illness, people of color with serious illness, about this tool. And people really, I think, we weren't sure what to expect, but with the language that we have, people were really open to the idea of having these conversations and felt like it might improve their relationships with the clinicians who engage them in this, which is very similar to what we saw with the serious illness conversation guide. I will say that the problem that we had getting feedback from Black patients about the serious illness conversation guide originally was they were like, no physician has ever talked to me like this. No physician has ever asked me what was important to me as a starting place in talking about what came next, ever. So they really had a hard time giving us specific feedback. I think that in this case, we were able to get, we used the principles that we learn as palliative care clinicians about asking permission, and then just asking kind of what we felt were human questions and refined it over time. So that's kind of a long-winded answer to your question, but I'd be happy to talk more about the trace tool as we learn more. Okay, thanks. Yeah. Oh, yeah.
I just want to thank you again for coming and sharing your great work with us and sharing your stories with us. Thank you so much, and thank you for everyone who came to join us today.
Yeah, thank you for being here.